Okay, so that's the plan for the day. I'd like to get us moving right into our first session on building the network foundation, part 2. So those of you who are on this panel, Jeremy, Devin, Jeff, please come on up. While they're coming up, I want to remind you that we started our discussion about building the network foundation yesterday, and at that point we talked about a number of issues related to governance and sustainability. Please sit anywhere. Governance, sustainability, some issues related to patient engagement, patient centering, or one of the other terms that Sean coined yesterday. And today we're going to continue discussing some of the key infrastructure issues for the foundation of PCORnet. So today we're going to hear from, or we're going to have a chance to talk with the task force leads from data infrastructure, privacy and bioethics, and regulatory task forces. The focus of this session is going to be more on the informatics side. What kinds of capacities are going to be needed for developing the capacity to include data from different participating centers in the analyses done by the network. You notice I avoided the term data sharing, Rich. And what are the core capacities needed to make that work? So hopefully we'll have some good discussion on that topic. But we're also planning to build on the session yesterday and dive deeper into some more of the important implementation issues around human subjects and study protocols, safeguards and protected health information, and the necessary infrastructure for exchanging the content required for doing the analyses of PCORnet. So joining us are those leads: Dr. Jeremy Sugarman, the Harvey Meyerhoff Professor of Bioethics and Medicine at the Hopkins Berman Institute of Bioethics. Jeremy co-chairs the Regulatory and Ethics Task Force. Devin McGraw, who you heard from a bit yesterday as well, the director of the Health Privacy Project at the Center for Democracy and Technology. She chairs the Privacy Task Force. And Dr. Jeff Brown is an assistant professor in the Department of Population Medicine at Harvard Medical School and the Harvard Pilgrim Healthcare Institute. Jeff co-chairs the Data Security Standards and Data Infrastructure Task Force. So I'd like to start with comments from Jeremy, and then we'll go to Devin and Jeff, and then we will go to discussion.
Great.
Okay.
Thanks, Mark. Get this one.
Should just be able to click.
Down. Oh, they're down here.
Yeah.
All right, thanks. It's great to start the morning with ethics. Got it? Regulatory in the morning? Come on now. Gonna give it up for a little ethics stuff. This is good. This is good. Looks of shock and dismay. Actually, as Rob Califf mentioned and Josie Briggs mentioned yesterday, in the NIH Collaboratory, we were surprised at the very beginning that much of our conversation during the initial year was devoted to questions of ethics and regulatory issues, which sort of held center stage in order to mount a series of pragmatic clinical trials. We suspect that every group here is going to encounter together a set of ethics and regulatory issues, and we are here to not only just watch them, but also to help you work through them. The ethics and regulatory minefield of comparative effectiveness research is fairly substantial, and we suspect that there will be issues, despite all the planning that goes ahead, about what's appropriate in terms of consent and notification. In some settings, a full, robust, informed consent process may be the appropriate way to go, but in other cases, a more truncated model of letting people know that some kind of research endeavor is taking place may be the appropriate way to go. There are going to be ethical issues in that, there are going to be pragmatic issues with that, and there are also going to be some regulatory complications that are going to put constraints upon the ways in which we can go about notifying and informing people about what types of research activities are going on. I was struck yesterday by the data that was presented about the patients' attitudes towards something as simple as having their data entered into dbGaP, and the responses that some of the people in the public have to something that we might consider a minimal invasion. So on the one hand, while there is a strong moral claim to access to research and moving research forward at a really quick pace, there are also, on other kinds of research efforts, another sort of swing of the pendulum the other direction where people are saying, we want to be a part or we want things to be transparent. And we're going to have to strike that balance. Determining minimal risk, it sounds like a real eye-opener in the morning. Minimal risk, as those of you who walk in the federal regulations of 45 CFR 46 and its subparts, know that the determination of when we can waive requirements to obtain robust and full informed consent hinges on this very issue about whether the research poses minimal risk. This seems easy at first glance, but in fact has stopped IRBs in their tracks, known as stopping molasses is really interesting, but it can really pause people. The scholarship on this issue is actually confusing, and it's actually a very difficult determination. But without a determination of minimal risk, we don't have the leeway under the regulatory paradigm we will work in to waive consent and other elements. And so this is actually a really critical area that needs some more attention. The use of FDA-approved products. In the collaboratory, we experienced some very interesting observations where we had marketed products that are out and available for use, but once we decide to study them in a comparative effectiveness setting, what kind of procedures and who has oversight? Can FDA weigh in on something that is not under IND to tell you it's not under IND? What if the sponsor or a manufacturer wants to use a marketing indication following your comparative effectiveness research? So migrating these sort of complex issues of the regulatory paradigm is also going to pose some important questions. Issues of research design, although you've probably all had mandatory ethics training modules which bear little resemblance to ethics. I think they're called CITI. It rhymes like, I don't know what it rhymes with. But it's up to you. It's a cold day. I'll let you think about it. But the research design issues actually really critical to having good science, right? And central to good ethics is good science, and it starts with doing really, really good science. These issues may not get picked up on by an IRB, but these kind of issues really are incumbent upon us to make sure the research is designed well so we can get good results. Things like cluster randomization and pre-randomization have attracted a significant amount of scholarly attention, and again, the issues are not settled about the ethical acceptability of these procedures in different settings, and it warrants our close attention and what we can learn together about using them and employing them to show situations when they're appropriate and when they're not. Institutional review board oversight. No one got that one, huh? Coffee, it's placebo. The IRB oversight question about what's the appropriate model. I was intrigued as we looked at your responses to challenge questions about the very different models different groups have used to try to streamline and yet ensure appropriate IRB oversight. Sometimes that may be a central IRB, sometimes it might be joint agreements, sometimes it will be individual IRBs. It may not be that one size fits all, but we want to learn from the accumulated experience of what we can do together to make sure that IRB review is appropriately efficient and appropriately good and sound IRB oversight. Not just checking the box, but making sure it's good. Data monitoring, which has been attracted some attention. In a classic randomized trial with a single sponsor with multiple sites, we've got some of that sorted out about data safety and monitoring boards. But what the appropriate mechanisms are, statistically, pragmatically, ethically, about when do we monitor data, especially when most data may already be accumulated by the time a research question is being asked, and some of the more epidemiologic kind of research raises some interesting concerns that haven't been addressed. Privacy and transparency, obviously going to be critical moving forward, but how do we ensure people's privacy? And Devin's going to get into talking about privacy parts in a minute, but after she does, it's sort of beyond HIPAA, so I'm just advertising for your talk. I can't wait for it. I've seen her slides in advance. They're really good. It's about transparency. The issues here are going to be really important about ensuring people's privacy. As we know, the public is deeply concerned about privacy, whether it's health-related privacy or informational privacy or the use of your technology that are in your pockets and in your briefcases. It's really important. On the other hand, we need transparency to ensure use of data across these systems. Ethics and engagement. This has been I love this stuff. I mean, starting back from when I was training and ACT UP was sort of fighting for access to better research and faster research and fueling a movement towards patient engagement and research in a really important way. AIDS activism followed by cancer activism followed by disease-based activism, totally great in sort of moving things a lot faster than they did. Believe it or not, if you think it's moving slow now, you should have seen it before, right? And just capturing that energy, right, in an appropriate way, but making sure still that research is done safely so that the people who are trying to have treatments advanced, modern understandings are not trampled in the process. And what are the ethics of engagement? Who speaks for individuals with a disease? What's the appropriate levels of engagement, an area that's going to be challenging? And finally, you're all in the room together. Rob Califf used to refer to the 7 collaboratory projects as the Hunger Games. People just sort of vying for that last spot, and the question's going to be, okay, there are scarce resources, and people want to be doing good research, and that's phenomenal. How do we treat each other in that process? How do we acknowledge all the individuals, all the groups that are playing a role in deeply collaborative comparative effectiveness research? The International Council of Medical Journal Editors hasn't caught up with us yet, right? So how do we acknowledge this work appropriately? So what do we learn from the NIH Research Collaboratory is one of the ways we navigated these cases was to have early discussions with multiple stakeholders to clarify those issues. So getting everybody on the phone. Hopefully we'll have the resources to get regulators, sponsors, IRBs, investigators, community members, et cetera, on the phone together, or whether that's a WebEx or phone or in-person meeting, whatever it is, some mechanism to identify the issues, to work together towards finding a solution. There is nothing bad about that. And investigators need to articulate carefully why a proposed endeavor, if it is minimal risk, qualifies as minimal risk. Help your IRBs out. Help everybody involved. If you think it's minimal risk, make an argument for it on the front end. Our current plans are to serve as consultants on request to folks around PCORnet for the emerging issues and to catalog what we see. We're going to be doing some desk and document reviews where necessary to sort of help inform efforts moving forward. Towards efficiency in this program, there are broad moral claims, or we wouldn't be here, to garner knowledge to improve clinical care and to enhance research efficiency. Those are good things. We got to improve patient care. It's got to be through research. It's got to be evidence-based. And we got to become more efficient. Wasting resources is just not a good idea. Doing so, however, is going to be associated with some predictable and unpredictable challenges. I gave you the ones that I'm predicting. I can't wait to see how I'm surprised. The cool thing about having an ethics phone number is the calls you get from people all over with the strangest thing you couldn't make up. Reality is stranger than fiction. I mean, I get great calls. I don't know if it's a crank or really an ethics problem, right? I couldn't make this stuff up, and I've got a vivid imagination. All right. And with collaboration and communication, PCORnet's well-positioned to navigate these challenges and hopefully develop appropriate means of overcoming them. We may need new models and to test those and to use those, and that'll be part of our job together. So I'm going to stop and hand it over to Devin. I will say I do need to leave it around 11:15, so I'm going to ask that when we get to the discussion, if you have ethics questions, don't be shy. If not, Rob's going to answer them. Rob's does the regulatory half of this, and so he's going to give a different ethics answer than me. So we'll do that. Thanks.
Are these all on the same deck? Oh, super. Love that. I'm Devin McGraw. I met some of you yesterday. I'm the chair of the Privacy Task Force. I am the director of the Health Privacy Project at a nonprofit organization called the Center for Democracy and Technology. Yes, I am a lawyer. But I do policy work is what I focus on. And I feel like my job in doing this policy work is always to enable people to do what it is that they want to do with data, assuming they're not proposing something really crazy, right? I think ultimately the goal of privacy is to build the trust of your community in what you are trying to accomplish from a research perspective. And privacy and security, frankly, as well, are just a set of tools to get you there. To deal with the how to minimize risk is the underlying foundation of all decisions you make regarding data privacy and data security. The goal of our task force We have 2 goals, actually. The primary one is to work collectively within the task force to develop the policies that are going to govern, now I use the term data sharing in here, and we decided yesterday we're not going to use that term anymore, but I did these slides before we decided we're not going to use that term. But to the extent that there will be some data that is shared in the network, the aggregate data, that is the response to the queries that you're going to run within your projects, we still need a set of policies that govern that data, because each individual node on this network, each of your projects is going to have to trust that when you do share the results of what you learn, you're comfortable doing that, because we have the right set of policies that enable you to have that trust. And that's for the overarching network. But at the same time, each one of you is going to have to grapple with your own privacy issues with respect to the data that you're accessing in order to run the queries, as well as, of course, what are the circumstances under which you're comfortable sharing that data with others. This is the part where, for each project, you're probably going to do this a little bit differently, but you're going to be struggling, many of you, with a similar set of concerns. And if we can work together to develop a set of best practices to help you resolve them within your own networks and within your own institution, we'll be better off for it. And because we're doing research, we also want to learn and inform the greater public dialogue about how we should be approaching oversight of research with respect to privacy and security. What's the right way to do this? What are the right ways to do this? Because it's usually not just one way. So again, our specific aims, we need to develop the policies for the network. That is our primary challenge. But again, we also want to do some surfacing of what are issues that folks are grappling with. We're having some discussion about them, having some workable models for how you deal with them would be incredibly helpful to each and every one of you. We've teed up some potential issues that might be candidates, but we definitely want to do this organically as a task force. What is it that you're dealing with that you would find it helpful to have sort of larger discussions, papers on best practices written? So the initial sort of set of issues that we put down as potential are really just starters for the conversation. Data identifiability and de-identification methodologies. Models for sharing data, and approaches to transparency and consent. So I mentioned consent. Consent and dealing with informed consent in IRBs is primarily in the bucket for the Ethics and Regulatory Task Force, but there is a significant amount of overlap between what we'll do in our Privacy Task Force, what the Ethics and Regulatory Task Force will do, what Jeff Brown is going to be doing in his task force, and as well, we're all sort of part of an overall governance effort. So there's going to be we won't all meet together on every single call because nobody could humanly do that. But it's really up to us to make sure that all of that work is really well coordinated, and we are committed to doing that. When you think about the privacy issues, people automatically default to compliance with law. And to me, absolutely, you can't avoid this, right? You'd love for the law to be changed, but it hasn't, and it's not going to anytime soon, at least not that I'm aware of. And so at a minimum, you need to make sure that your particular institutions that you represent, then your network of institutions, that you are in compliance with whatever is the law that applies to you. The common rule, which is the NIH research rules, is one aspect that you have to think about. HIPAA, it's not going to apply to all of you, but is going to apply to a significant number of you, particularly on the CDRN side, and you have to think that through. 2, you have state law to take into consideration in some cases, and if you're dealing with a product that is being submitted for regulation, you may have FDA rules to have to deal with as well. But in some respects, the compliance with law piece is a little bit of a check-the-box exercise. Not that that means it's easy, but it's sort of, did we do this? Did we do this? Did we make this set of decisions that, should a regulator ever come knocking on the door, we know we have done what we are supposed to do. But that's almost the minimum in some respects. Again, the goal here is not, it is to be in compliance with law, as is always the case, but the goal here is to have a trusted environment for all of you, for the patients that you serve, for the people that you work with, that there's a level of comfort with the work that you're doing, both within your institutions and networks, but also across the network as a whole. And fair information practices, frankly, are the hallmark and the foundation from a principle standpoint of every single privacy law that's ever been written in the US and globally. And so when we're thinking about network policies, PCORnet policies in particular, openness and transparency, how clear is it to the people to the communities that we're serving and to the public at large, what it is that we're doing? How are we making sure that the data we're collecting is only exactly what we need to answer the question, and we're not sort of hoovering up every piece of data out there just for the purpose of having it? It's one of the reasons why we have a network that's constructed in the way that it is, which is to say that the raw patient-level data is remaining with you, and we're sharing just what's minimally required to answer the question. That's a hallmark of data minimization. Individual participation and control, that's where the piece about how much choice do you give individuals about what you're doing with this data? And it is not an absolute, right? You need to think through what is it that we're doing with the data? What kind of data are we talking about? What's the risk associated with this data, both from an ethical as well as a sort of privacy risk standpoint? And all of that sort of factors into making decisions about policies, oversight, et cetera. So data minimization is one of the principles that we're sort of exploiting right from the get-go with the structure of PCORnet, which is to say, again, that the patient-level data remains within your nodes, and what you're sharing with others is the results of what you learn. Approaching this model using this model is incredibly helpful from a risk minimization standpoint, which then makes it actually incredibly helpful from a regulatory standpoint, because frankly, both the Common Rule and HIPAA have much, what they care about is identifiable data, or data that has a more than a very low risk of being able to be identified to a particular patient. So when you're sharing data that, for example, meets HIPAA's de-identification standards, there's a level of comfort both from the regulation standpoint, but potentially also, hopefully, from your IRBs in terms of sort of what's the risk for that data. Now, that doesn't, you still have to consider, though, I'm realizing I just have a minute left, what you're going to need to do, because your internal access to the data is for fully identifiable data, and you also need to think through what your policies are going to be there. So what I had here on the slides is just a primer on what the Common Rule requires, what HIPAA requires, common challenges for networks. You can have 10 lawyers in a room reading the same law and get 10 different answers about what it means. And I'm sorry about that, but there's actually a bit of a path through it, which I believe involves conversations amongst one another so that the lawyer in your institution is aware of what the lawyers in other institutions have said about where the risk calculus lies. There can be a bit of sharing of learning, so not necessarily so that you're trying to make everybody make the same decision, but you're helping your compliance officers get comfortable that they're not way out there on the limb doing something that nobody else is doing, because there's nothing scarier to a lawyer than being the only one out there on that tree limb. Part of our job will be to make sure that that impression does not rule the day. We're going to be working on that. So some of the questions for discussion that I had teed up, but obviously whatever direction you all want to take this in, is, do you have policies and procedures within your networks already that you're ready to deploy? If you're more than one institution or group, have you figured out a way to sort of work together as a network already, which then will get you one step further to working in the larger PCOR network? If you're not there yet, what is it that we can do to help you get there? Because we want to help you get there if you're not there already. And are you prepared from a policy standpoint, in terms of sort of all the permissions that you need to get to be able to work within the larger network. We want to help you get there. This is not an insurmountable challenge, but it is a challenge.
Well, Devin, you pretty much said what I wanted to say.
I did?
Yeah.
Well, good, because I went over a little bit.
Well done. So this will be easy. Wow. So you should be getting the impression that the distributed approach to doing research is where we're going. So I'm gonna, Jeff Brown, I'm the co-chair of the Data Standard Security Networking and Infrastructure Task Force. Each of those could be task forces, obviously, but we're all together. So I'm co-chair with Leslie Curtis, who is here, and Ed Hammond, who's smart enough to be in North Carolina. I'm sure it's sunny and nice there. And we have a team between the folks at Duke, so Leslie and Ed are at Duke, I'm up at Harvard Pilgrim, and then we have a kind of teams of folks between the two to try to manage the task force. So I'm going to try to give a pretty high-level view of what are essentially the guiding principles that have been kind of given to us by PCORI of how we should be trying to coordinate across all of the awardees. So we have this challenge. All the awardees have been funded to do work, and then we have this responsibility of trying to work with all of the awardees to build what essentially becomes a network of networks. So we'll need a lot of help from you guys to do that. So the basic aims here, so we're calling this the PCORnet Distributed Research Network, so that is this idea of this network of networks. And one of the key principles that we'll follow is to try to build on things that have already been done. So yesterday we heard from ARC and FDA and CDC and others, ONC, I know ASPE's in the room. There's a lot of federal work that's been done along these lines of being able to create to leverage data resources across institutions. So to do distributed research, and then now we're raising the bar to doing a network of networks. And folks in the room have been doing this for a long time. So we have to start using all of the tools and expertise that's in the room and that have been built around the country to move forward. And it's been a very explicit instruction of don't start from scratch. It's a silly thing to do, but it's also nice to hear that as a very explicit approach that we have to follow. So for this, the task force kind of key responsibilities, what do we have to really do? We have to try to create this distributed network, this network of networks, to be able to engage across the awardees efficiently. So to do it, you can engage across awardees, but to do it efficiently is a different kind of question. So we have to think about how to do that. And you heard Devin talk about this. The data, there is no central data repository. We're not thinking about it. It's not one of the things on the list of the possibilities. Your data stay behind your firewalls. We're sending questions to the data, and really want to get the minimum amount of information back. So we have to think about, that's not that easy, right? It's much easier to say, can you just give me everyone, all the women over 40, because I kind of want to do a study. I'm not really sure how I want to do it. But if you just give me all the data, I'll figure it out. That's not what's going to happen. So we're forcing ourselves. That's easy for the researcher side. But that's not how we're working, not how we imagine this working. So we have to force people to think through really what do you need and what information do you need to actually do the research. You might need very little to come back to the PI. The PI is not going to be me. The PI is wherever the PI is. They really have to think through what do you need to answer the question. It's not what you'd like to have because it'd be nice to have, but it's what do you need for the question. And I think that's really important, and it's hard to do. It's just harder to do it this way. So that part of that is the distributed analytic methods. And folks in the room have built some really sophisticated tools to do this, and we have to try to kind of build a network that can take advantage of those tools to do it. So how do we build this network? I listed 3 pieces. I'll try to go through each one. To create a network, some of the building blocks there are an operations center. So that's really the task force folks. to try to make something work. We have to, this isn't just a virtual network. There's a portal, and there's people, and there's tools, and there's knowledge management that we have to take advantage of. And I'm hoping we can talk about kind of that piece kind of during the discussion of the really nice advantage that PCORI's given us is to build something that really can learn. We've all done probably research project. You do the project, you learn something, you find out something really interesting about your data or a place in your data resource that you don't want to go near again, but no one ever knows about that, and the next person that comes along might fall into that same trap. We have this chance of learning so that we don't do that. So as an operations center, there's the operations center, we will find a way, or we'll build a tool so that we can securely send questions and you can securely send an answer. So these are the pipes. That's the pipe of a network. This is not going to be a network just a bunch of email addresses that we send emails to. So there's pipes to securely send questions out and get answers back. We have to be able to do the querying, and we can talk about that in more detail, and we'll really get into the detail when we talk individually with each of the awardees kind of over the next month. Again, keeping the data back at the data partners, for the folks, the awardees, that's where the data will sit. And the system that the way the architecture of this kind of system works is we will send you questions. We have to build a system to enable this, right? We will send you questions. You will get the chance to see what the question is, answer it, and it doesn't leave the building until you say it's okay. So that sounds like a lot of manual steps. That's because I don't want to have to talk to Devin all the time about how to make that an automated process. But that's why it was built that way, because it's consistent with the regulations and the privacy rules that we have to follow. So that's a different approach than it shows up at your door, it runs and sends a blob of answer back that you never got a chance to look at. You can do that, but that's a different approach, a different privacy kind of infrastructure you have to build in order to enable something like that to work. And that's not how we're doing it. So if you have local workflows, keep them. So I'm sure Devin really hopes you have a local workflow. So what I mean by local workflow is some decision process for deciding, will I answer this question, and am I willing to send this piece of information or this data set or whatever it happens to be back out to that requester? I expect that most folks probably have some way of doing that, and I'm sure that it's different everywhere. That's okay. We're not trying to impose a different workflow on your approval of a response, right? So it enters your door, your workflow, and then you decide whether it gets released. And then the distributed analytics, I think there's a lot. This is really just to highlight again that we want to do as much of the data processing, manipulation, analysis as we can behind your firewalls, so you only send back what's necessary. So we've done actually some pretty sophisticated, we've done some pretty sophisticated work on just sending back things like risk sets. I know there's other folks in the room that have done logistic regression without sending any patient-level data back. You can do logistic regression by sending around basically the program and the parameter settings. We should be pushing that because it avoids having to talk to Devin. Right? Not that it's not fun to talk, right? But that's the idea, right? So if you can do it, let's try to do those things. Many of you have probably seen this picture. This is really just a visualization of how we're imagining the network. This top part, think that's people. That's the operations center. Those are folks who understand how to do this work that will facilitate it. This portal, that's actual software. There's a login, and that's where you can either create a query, or if you show up with one, you can send it out. It will go out to the network. If anyone has a better way of showing a firewall, can you send it to me? Because that's the best I have, and I know some folks don't like it, and I'd be happy to change that, but that's all I have. So you will pull it into your firewall, you do your work inside your system, and then you release the data back out. So that's the basic flow of this. And to do this, there's a set of building blocks. So our goal in this task force is we've got to keep moving forward down this path of being able to create this network. We're going to look for short wins so we can kind of keep building on them. So the building blocks are the awardees, a set of guiding principles. So it'll be very important for us to decide together what is the network supposed to do in terms of guiding principles, and then we'll build from there. An operations center, which I described. We have to figure out, we have to deal with data and the data models and how are we going to handle that. And the thing I actually didn't include here that I should have is the steering committee and PCORI are an important part of this building block, right? We have direction from PCORI and from the PCORnet steering committee of what we should be doing and what our goals should be, and we have to make sure that we keep those in mind as we go forward. So that's going to lead us to doing things in short cycles so we can learn, adjust, and do it, and use that process rather than try to build something and release it or unveil it in 18 months. That's just not going to be the way that we'll be able to do this. And that's it, Mark.
Great. Thanks.
Back to you.
All right, we're going to open things up for discussion now, and we're going to try to have this as interactive as we were able to do yesterday in a more constrained space. You heard from Jeremy, Devin, and Jeff about a number of issues. Jeremy does need to leave soon, so if you have any specific questions or concerns about ethics, it'd be good to get those out first. But I'd also like to highlight the presentation that Jeff did about the underlying distributed analysis model that is at the heart of all this and that plays into how the ethics issues can be addressed, how the privacy issues can be addressed. So I just want to make sure there are not any more fundamental questions about what that model is, how can it work, what is the common data model feature underlying it, and how can that work. This would be a great session to get all of that out. Can anybody help Jeff with a depiction of a firewall that doesn't look like some kind of cubist bonfire? Any of those are all fair game. So I see some hands up already, so please go ahead. And there's a microphone on the table, so if you could use that when you're asking.
All right, start with Jeff, George Ripsack, Columbia University with the New York CDRN. One thing I didn't see a statement is all our stuff we produce, is that going to be open source? Like, are we going to only use open source code? I ask that because nowadays when we work with NIH, if it's not all open source, even IBM wouldn't work with us because we didn't say it was open source enough. And so that's one question. And then the other is, I think looking, and that's what I was trying to do yesterday, look across the CDRNs and PRNs to see what's already common among us to decide how to move forward on terminologies, data models, and so forth. Because a lot of it, a lot of us ended up with the same solution without talking to each other, and we might as well take advantage of that. So those two issues.
So, and is this sounding all right? Yeah. We're good. So I think, yes, open source, I think that's the way to go. And anything we build, I think that's just the decision we've made is we build it, make it open. And so you gave me a good chance to say thank you for filling out those surveys that we sent out, because we've been looking through them, and it's not as, there's some consistency across them, but it's really diverse. I mean, when you start to look at across the CDRNs, and then within the CDRNs, the institutions and what data they, just what terminologies they're using, what kinds of data they have, it's quite amazing how, well, I guess I shouldn't be surprised. In the US healthcare system, it looks like everything. But what we have to do is figure out where are those consistencies and take advantage of them. It's not as, I was hoping everyone would be doing one or the other. That just didn't happen. So now we have to think, where are there enough consistencies that we build on it? And then where, some of these things aren't that different. And then figure those out. And I'll just call that's going to be fun.
Okay, go ahead, and Mark, I'll come back to you. Yeah. Microphone.
So I actually find it a bit curious that there is tremendous diversity in a community.
There we go.
I find it surprising that there is this much diversity in a community that everyone's trying to accommodate meaningful use, which really pushes certain data and syntactic standards. The survey that we all completed was obviously a snapshot, but most of us are migrating fairly aggressively towards standards that ONC is pushing. Do you anticipate that being something that's going to be aligned with the effort we're doing?
Yes, we'll have to. So we have to build something that, I guess, what should I say, that assumes that everyone really will be following meaningful use at some point. It's not, so when you start to, you're right, it was a snapshot. To do longitudinal work, it just causes a mess now that everyone's kind of changing. But we have to be able to assume meaningful use, those standards, and build towards those and not build looking backwards.
I just want to sort of clarify what we're doing. So we do have a couple of reactors for this panel as well, but I wanted to make sure if there were any comments specifically directed towards Jeremy or any sort of basic questions about the distributed analysis approach, so we had a chance to get a few of those out first. Also, while I've got the microphone for a second, I know we've got a lot of people participating in the webinar. Some of you online have asked questions about whether there's a conference line. Since we're able, because our full systems are in place now, to do both the video and the audio through the webinar, that's the mechanism to use to both hear and see what's going on. So I'd like to go to Mark for a question here, and then I saw a couple more hands up for specific questions about hopefully about the basics of the model, or especially ethics issues. I'd like to get those on the table, and we're going to go to our reactors.
A specific question about the distributed data analysis. It's a little bit of a specific question, but I think it helps. It's going to determine our approach to data collection, I think, which is if you have a single person where you collect some variables behind one firewall and other variables for the same person behind another firewall, is it possible to do a distributed data analysis in that situation?
So that's a great question. It's something we all run into, right? Just in the U.S. healthcare system. We won't be able to. So from a coordinating center kind of operations query, I won't be able to send you a query that has an ID and is able to unify those. I'm hoping that you guys, if it's within a CDRN, will deal with that. Maybe you will, maybe you won't, but I'm hoping within CDRNs, maybe you'd be able to come up with some unique identifiers and solutions to it. Out from outside, that'll look like two different people to us.
Well, I mean, it is a basic challenge, just to pick up on Mark's comment, that if we've got research networks that in some sense have overlapping populations, you may not be able to solve those issues just within a single CDRN. And that does sound like a real methods challenge for this group to address going forward.
Yeah, and I feel like we should just keep our mind open to the possibility of some data sharing arrangements being useful in the network.
Yeah. And I think I guess I want to point out that we're doing research, right? So we should be sharing as much information as needed to answer the question, right? So if that's what we need to do to answer the question posed, these guys say it's a good enough question that it's real research and it's appropriate to ask, we should share as much as you need to. So I think that's where I would. So I don't want to draw the line of you never share. It's you share as little as you need to answer the question, but that might be patient level, and it might have identifiers. That's okay, but you don't want to just do that.
Okay, I see a lot of hands up, and I'm glad we're getting a good discussion going about the actual mechanisms and challenges of doing distributed data analysis for comparative effectiveness research. Let me just ask, are there any specific questions about ethics issues to Jeremy? And then we're going to come back to these others now that we've got the discussion going. So, go ahead.
Alex Sherman, Mass General. I was wondering, so my institution serves as CCC, Clinical Coordinating Center for NeuroNext. I don't know whether you heard about the project NINDS, where we have a single IRB and single contract template among 25 institutions. So do we envision something similar here where we have a single ICF consent form template and single IRB perhaps, or single protocol, contracts, or something that will facilitate research?
So it's a great question. So there are a lot of models like that that have grown up inductively in different groups that we'd probably want to exploit where they're already available. Negotiating those agreements could take an extraordinarily long time. So getting IRBs to relinquish control to one another can often be difficult. Learning to trust one another. The activation energy is pretty high. Once you get to a sustained model, things tend to work out. So I think what we want to learn from is what situations do those sort of models work? When don't they work? And for IRBs that haven't used those models, what can they learn from these networks to begin to develop enough trust in the system? Because we do want to accommodate really good reviews. The notion of the single institutional IRB was grown up on this idea that local knows something about local. And how we incorporate that in a meaningful way into centralized review is really the trick. And so I guess we can learn from these models. So no master plan to say tomorrow all your IRBs will agree. That will never happen, right? They're not going to agree right away. But I think learning from those models is the way to go.
Learning from them and, as Devin was suggesting, identifying best practices, getting the lawyers to talk to each other.
Yeah.
That's,
Yeah, no, if you can convince them that either it was their idea to begin with or they're absolutely convinced it's a good idea, but you're not going to press that down on them.
Other questions on ethics directed to Jeremy? Yes. The microphone behind you. And be sure to press the button.
Good morning. In representing a patient advocacy group that's standalone, has just recently entered the wonderful world of IRB-hood with a patient registry. The compliance environment is a little challenging for us from an organizational structure perspective, that we weren't really a research institution, but now are we? And so we hope that this task force will provide not only compliance advice, but practical for the entities that are now in this network.
That's a great question, and hearing precisely where the different groups are with what their baseline is and what you need is going to be a useful starting point. I would actually say going even beyond compliance about why we're doing this, right? So getting enough engagement about the ethical reasons for doing this makes the spoonful of regulations go down a little bit easier. And I think knowing the why and the how come and the ought is really important for driving that forward. And so hearing those needs will be helpful going forward.
If I may, a quick follow-up again. I think those of us steeped in it day to day get it, but our board, which is our decision-making group, is not. So that's another stakeholder in some ways. They talked about the CEOs of healthcare institutions weren't here yesterday. Volunteer board members are a stakeholder constituency in this process as well.
And you need to build their trust for.
Yeah, and I think getting at why we have these protections in place, and for people who, especially people who haven't been familiar with them, is important. You may remember for about 15 years ago, multiple large-scale academic institutions around the United States were temporarily shut down. The research programs were shut down by the Office of, what was then OPRR is now the Office of Human Research Protections. And what was central to getting institutions to buy in, even those that had been doing this a long time, was backing out to say why we have this framework in place. And then, you got a lot of smart and motivated people, and they just need to, you can't wake up in a morning and say, I understand the rationale for the regulations. Maybe a lawyer could, but I can't. So, the idea there would be to really get that in there first so people understand why it matters.
Great. Thanks, Jeremy. I would like to go now to our lead reactors, and we've gotten a bit more of a foundation for this discussion from the initial reactions of many of you. They are Sean Murphy and Peter Merkel. Sean is the Director of Research Information Systems at Partners, and he represents the Scalable Collaborative Infrastructure for Learning Healthcare System, which is one of the CDRNs. And then Peter, who we'll hear from after that, is the Chief of Rheumatology at the University of Pennsylvania and represents the Vasculitis Patient-Powered Research Network. So Sean, please go ahead. Press a button. Yeah.
There we go. Thanks a lot, Mark. And so I just wanted to say, so if I was Joe starting out and trying to envision how could I actually get something like this at this magnitude to work in 18 months, I think your solution is brilliant. how do you implement that? So the chances of getting some big central thing working, almost nothing. But look at all the great networks that are out there. So unify those into this network of networks. And I think that's the key to the implementation that we have here. So all those regulatory issues that we've seen, all that trust that each network had to get with all their constituents is now in place. And so that, which takes enormous amount of time, sticking to that, I think, is very important. So this idea that we have a coordinating center that then farms queries out to the central hubs of each CDRN, and then they kind of do their stuff, get their data together, do all the queries, you know, rustle around in there, get things together, and then get it ready for an analysis, I think, for each disease is very important. And this ability that, so in developing this agenda, I think we've done a great job in thinking through how to actually make a decoupled system, which is the key to getting anything like this really well functioning right from the get-go. And I think that that's extremely important. So understanding like what exactly, how we're going to manage this operations center so we can maximize the autonomy of our groups but still bring the analyses together, I think is going to be the critical feature of much of what we need to do. And I respect Jeff a great deal, and I trust that is what we're going to get done. And so I'm great. And I think that, you know, Devin, and I'm sorry Jeremy left, is just about as good as we could get. So this is, we're in good hands. But I do think we have to keep these things in mind. We got to make sure that we have, you know, the ability to adapt to what various groups are doing, and that we work on the interconnections between the groups in ways that keep them decoupled from each other so they can continue what they're doing, continue their paths, and yet at the end of the day come to these big conclusions which we're all foreseeing.
Thanks, Sean. Peter?
We're here. Hi. So I thought about this because I got your slides ahead of time. I have a number of issues. I wanted to raise a couple of points and then challenge the group to think about some things. Just a few rare disease specific issues, because rare disease group and half of us are, just to remind some people that actually I would posit our experience is that patients with rare diseases are extremely willing to share data, and actually more so than others, and incredibly voluntary for research. They also need more protection because, in fact, if your child or you are the only woman with that disease in Montana, you're very identifiable. And so there are different issues there that we have to protect our patients from, and et cetera, even though they want to share. We have to work together and figure that out. But people can give up their rights as long as they know what they're doing. The need for central IRB of record, which our group has successfully employed without as much bother as people seem to think. Actually, I really think that's not, I would disagree. I think that if you are strong and push it through and you say you either are going to do it this way or you won't get the money and you won't be part of the study, you'd be amazed how quickly institutions turn around. The Mayo Clinic, the Cleveland Clinic, University of Pittsburgh, it happens. And if you give them a pathway that they can walk down and there's no minefields and your lawyers say, you know, we've done this, they're actually happier. And so I think it's doable. But the need for that is actually even more so in rare disease because it costs just as much to run a study with 10 patients as it does with 10,000 patients at a particular site. But those are specific issues. I also think PPRNs have different issues than the CDRNs very much. We can't assume that we're going to have institutionally anchored regulatory issues. We're not going to have even 10 institutions. We're going to have 500 institutions or centers or practices. So you, by definition, either whether it's Penn or if it's MGH, are going to have to hold on to it, run that for all the people who are joining that network. So it's a very different approach. It's actually it's both daunting but actually easier, and it's different issues. So I would say that, back to my other point, is I think that we bring, as a PCORI, governmental or quasi-governmental, whatever we are calling it, as I said, I think the other day, if we bring facts that are actually correct, if we know the law, if we have OHRP's blessing and FDA's understanding, et cetera, and we go and say, this is a pathway that is legal and works, we have authority Institutions are risk averse, but they also were happy to give up authority if they think it's right and it's less work. So I think that's the approach that we have taken. We're doing an online study. We have an OHRP. A letter from OHRP says what you're doing is appropriate and correct, and it has gone a long way to help us. So I think there are ways to do that. So I would say that we don't want 18 different consent form languages for how to share electronic health records. We don't need 18 different ways for children to join, and for DNA if we end up banking things. I think the local approach, IRB, there's no data that has actually protected patients. There are some that it's certainly hurt research and not gone forward. So I would say, I would challenge to us that let's be more of a network than just a network of networks. I think that, in fact, we could be stronger if we actually pool some of these ideas and move forward. As Alex was saying, I think we can do some of this. One size does not fit all. I recognize that. But we don't need bespoke tailoring for all things. I think that, you know, small, medium, large does actually sell a lot of stuff for J. Crew, and I think it would work for us. So I would say, I would actually challenge us and pause it and see what people think. Let's aim for a select small set of standardized consent modules that you can mix and match, IRB approaches, DSMB charters. You can opt out. You can do what you've done if you like it. I would say for many of the groups, especially I know the NEFCure group is starting at some of this. If you haven't done this before, having a package you can take off the shelf, she's nodding, would be very helpful. And if we do this right and we have a good product, because we have really good people here who have done it, I think more people will adapt the actual network approach, the branded PCORnet approach. You don't have to. I would say that that's true if we're going to do FDA and other regulatory things. I like the SWAT team approach, the idea that we would have a team of people that would help, perhaps not as aggressive as that term. We need to come up with a nicer term. But we're from PCORI, we're here to help. And I would say that we should address these tasks practically, but also remember this is actually scholarship, that we can actually, we can write this up. We're going to create product. We're going to create approach to doing integrated, distributive, online methods that we could actually be proud of and export, and that actually helps our overall goal of promoting what we're doing. And so I say, I would challenge us to try to be practical and think about this, and I'm wondering what other people say. So I was supposed to react, so I reacted.
Quite a reaction, both from Sean and Peter. Sean, in terms of some of the benefits of having this kind of distributed analysis network in place, and Peter challenging all of you about the question of just to what extent would it make sense to have standard modules developed to deal with some of the core issues of consent and privacy, and that could extend to developing some of the data models too. And these are not mandatory in the sense that not everybody has to participate, but would be part of the requirements for PCORI funding and participating in PCORnet. So a lot to react to out there. Please go ahead.
So even though I'm from Pittsburgh and the SWAT is the one you think of the guys jumping out of the van with machine guns pulled, I'm thinking about SWOT, S-W-O-T. To understand the strengths, weaknesses, opportunities, and threats that institutions feel when they come up against these issues. And so to reframe the SWOT, it's the SWOT that's strategic, that a task of brilliant people come in and help institutions get over their barriers, just to clarify, even though I'm an avid Steeler fan.
Other comments? So go ahead and just press the button.
Hi there, I'm Mike Kappelman from the University of North Carolina and the Crohn's and Colitis Foundation of America, PPRN. And I've experienced, and I wonder if other PPRNs have experienced a tension, and this is something that sort of as we were putting our proposal together, kind of, I just felt conflicted, or at least divided between two opportunities. One opportunity was the ability to collect standardized data types in interoperable formats so that we can all work as a network to answer these pressing comparative effectiveness questions that may be more general, versus the opportunity of collecting data that's disease-specific, that matters a lot to the patients that our PPRNs represent. And these may be data, whether it relates to exposures of interest or outcomes of interest that are high priority items, that are high on the research agenda, that have been identified by our patient populations. And that data might not be standardized or interoperable, but it's really pressing for the patient populations that we serve. And how do we do both? Answer our disease-specific pressing questions as well as contribute to this greater PCORnet? And how do we do both in 18 months? And might there be a process of prioritization? And how best should our PPRN and potentially the other PPRNs represented here kind of live with this dichotomy of two opportunities?
Yeah, I saw a lot of head nodding with that comment, especially from some of the patient groups who are here. Do either of you have any reactions or comments or Jeff, experience from your work on distributed networks so far?
Well, I'd certainly say collect what your patient population finds is most important. We'll deal with the way, the interoperability after. I mean, I think you focus on getting your data that will help you and your populations. If we have to have a bigger hammer to figure out how to do it, kind of make that work across, I think that's okay. I mean, all things being equal, choose to collect data in a way that's as standard as you can make it, right? So don't go pick a standard from Europe and try to make it work here. But so use one, but I would focus on getting the things you need. And I think this was talking to Sean yesterday out in the cold. We have to be data driven, right? So collect the data, and then, where have we been in for the last 30 years? We deal with messy data, and we'll have to deal with it. Now, you would hope that wouldn't be the way we have to do things, but that's kind of the way we have to do things now.
And so this does link back to some of the governance issues that we talked about yesterday. So if there is going to be a PCORnet-wide study in a particular disease area that matters to patients, yesterday we had some discussion about how do we make sure that the research questions and therefore the data that are part of that broader study do reflect the priorities of patients. And do you all see those linking up?
Yeah, I mean, focus on what is most important for your cohorts. If it's patient-reported outcomes that are important there, but no one else collects those, it's kind of okay, and we'll deal with it, I think, is the way that we have to think about it.
Could I see a show of hands again? Oh, did you want a quick follow-up on that?
Yeah, just a real quick follow-up. Sorry, I don't quite know how to use this microphone. I think to the extent that we're collecting data on medications or diagnoses for a problem list or even lab values, that part's easy. It's no-brainer. It's a no-brainer, and it's kind of pan-disease. And I wonder if we have the opportunity now for working together on other types of data standards for issues like fatigue, which may be common across all of the disease groups, or exposures like diet, which may be common across all disease groups, for which the existing standards and EHR standards and meaningful use standards might not apply. And I think if we plan like now, or maybe even 6 months ago, for some of these other types of data and data standards that may be more applicable, we can maybe do both.
That's actually a great point. I mean, so Leslie and I have been talking a lot about this, in terms of if there's things that folks want to collect, particularly across, I don't think we feel like we should direct how you should collect fatigue, but if between your PPRN and 3 others, fatigue's important, that would be great if you got together and said, we're going to collect it this way. There's probably no right answer, right? No one's, so within this community, say fatigue's really important. Let's collect it in this way and just do it. And then that's the PCORnet standard. And that would be fantastic if groups would do that. And I certainly don't think, certainly from our task force, that's not us to tell you how to do it. I think that's you guys saying, we're going to collect data in this way. You have any problem? They'll say, no, I'm really happy you did that. And all of a sudden, that becomes a pretty nice standard.
And this does need to link back to some of the governance discussion yesterday about how this overall network sets the priorities for where those standards would be prioritized and developed. Okay, I see hands again. I go back to the back of the room there, and then we'll come over here. Go ahead. Can you microphone behind you?
Sorry, I just wanted. This is Amy.
Press the button.
button. Hi, this is Amy Abernathy, and I chair the Patient-Reported Outcomes Task Force. And just want to follow up on that last comment, which is one of the goals of task forces like Patient-Reported Outcomes is to help to support as we think about creating standards and consistent ways of assessing issues, especially in terms of patient-reported information like fatigue, pain, insomnia, and other important areas. So I would hope that we work together on this to not only figure out the best way to do it, but also to make sure that together we understand how the different groups are doing it well.
Thank you, Amy.
Thanks. Over here.
Hello, Robert McBurney from the Accelerated Cure Project for Multiple Sclerosis. Yesterday, when I spoke briefly, I didn't say one of the things that we hope to contribute to the network. But Accelerated Cure Project already created a biorepository that represents 3,200 people. And in doing so, a group of really smart people put together a 52-page case report form to collect what is about 30 million data points on those 3,000 plus people. We just had a great benefit of support to curate all that data. It is amazing how much you can learn in a process like that about when to use free text, when to use drop-down menus, et cetera, et cetera, et cetera. And we would love to contribute to any other networks that are developing patient-reported data, those learnings, because despite the fact that a collection of really smart people from physicians interested in MS or to treat MS patients, down to patients, to engineers, we realized that just simply asking people about their medications can lead to hundreds of ways of expressing the same thing. What you constrain and what you don't constrain and how you use that is enormously important. And so we're ready and willing to contribute to that and look forward to the contributions in the reverse direction as well. Thanks.
Thanks, Robert. From these comments, it does sound like there's a lot of interest in a early priority for the network around developing some standards and more widespread use of some key, meaningful patient-reported outcomes that matter a lot to the patient groups here. Please go ahead.
Hi, Paul Aviak from Harvard Medical School and on the PMS-DN, PPRN. The approach you presented, I'm glad that you took this approach of separating so that there's a centralized way of presenting the queries, and then it's disconnected to make sure that each site do it the way they used to do it. That's exactly the way we did it on European project, the EU ADR project and the EMIF project, where I'm involved on those two projects. The second one, the EMIF project, the $75 million, 53 million patients across Europe, and we are doing exactly the same approach of disconnecting. What we learned from the previous project, the UADR, on this EMIF project, is the importance of having something harmonized, being centralized, to make sure that when you define acute myocardial infarction, it's not just to select one SNOMED code or ICD-9 code of acute myocardial infarction. What we realized is that each site has to make sure that we all agreed on exactly how we were defining it on top of it. If we didn't do that, that was a real mess because it wasn't just a code selection. It was much more complex because of all the different mappings that were behind. So my question is, how are you going to centralize and harmonize at the beginning of your request?
So I was part of that EU ADR acute myocardial infarction query. When I got that request, they said, "Tell me how many people had a heart attack." I said, I'm going to need more information than that. A heart attack this year, a heart attack, there are 100 ways that I could have answered, and I answered 3. I gave 3 different answers with 3 different rates because we weren't, we did that on purpose to show that issue. So there's a couple ways of doing it. The first thing we have to do is understand the data as it sits at all of the institutions. Some people have inpatient data, some people have inpatient and outpatient data. Those are two, the same algorithm will get you a different answer. And it's part of the operations center responsibility to think about understanding all of the data as it sits at those institutions. How do you do it? I might almost just leave it there, because there's, beyond that, it's just whether we force more standardization out into the networks, which I'm hesitant to do, or work with each network to say beforehand, how would you do this, and see how it's different across institutions. So one of the things we always do, maybe I'll think of it this way, we always want the local institution, whoever's holding that data, to help us think through the question. What we certainly wouldn't, I don't think about it as, I'm going to send you a question and just give me the answer. It's more to the extent of, we're thinking about this kind of exposure and this kind of outcome. What do you think? Is it okay that we do that there? Is there anything we need to know about your institution that would make this a silly question? Or have you already done this? And we'll get learnings as we do that, and we won't have to ask as detailed questions every time. But we have to be incredibly humble in how we use data across, within your networks. You'll learn it. If you haven't learned it already, you'll learn very quickly that the data that you think are all in the same form actually can't be combined unless you really work hard. And across networks, it's that same complicated issue.
Okay, thanks, Jeff. I had a question back here.
Yeah, so Richard Milarski from the COPD Patient Powered Network. I really want to channel the energy from yesterday, which I think had much to do with opportunity and being visionary. And mostly, I want to channel the patient voice here. I think there's a huge missed opportunity and a chance for us to not capitalize on what PCORI has done, which is bringing patient organizations and provider data centers, EMRs together. And I think this idea of decoupling and keeping within our firewalls is going to be extremely detrimental. So let me give you an example. A patient may come to our PPRN and register as having COPD. We know that 65% of those patients are going to have 6 or more comorbidities, and so they may also go and register with some other PPRN, and there's no way we're going to know that that same patient is now in 2 PPRNs. So first, we have a horrible issue of duplicative data. In that we don't have unique patients across our network, and our queries, if they're going to rely on this decoupled and centralized data analysis, will be double counting that patient, for instance. More importantly, this same patient who may live in Portland, Oregon, might get their outpatient care, at Jen's Ocean Clinic, and so there'll be data there that we won't be linked to, even if we, want to somehow take advantage of this blue button technology. Where are they going to send that data? Are they going to send it to Jen's network, to my network, or maybe they get hospitalized at Kaiser, and now suddenly they're in Beth McGlynn's network. And so if we don't have a way to have a unique PCORnet identifier and be able to link information across our various components, it's a huge loss. So let me take this one step further. We have genetic information that's being housed in Denver, and there's going to be many other places that will have genetic information available on patients across our network. But how will we ever, access that? And then most importantly, we heard yesterday that patients don't want data, they want answers. And we heard yesterday that patients don't necessarily care about the quantity of their life, they care about the quality of their life. So we've heard about patient-reported outcomes. If especially the PPRNs are going to be deft at collecting things like dyspnea, health-related quality of life, maybe even ones like a EQ5D that can translate to QALYs, and we can't link those to all the data that's existent in the CDRNs, then we've really missed the mark with this effort.
We talked about this issue. Mark's question earlier brought up the challenge of overlapping patients across networks. I think this is kind of a more pointed version of that, and this something that you really highlighted was that the kinds of data that are in some of the PPRNs are different than some of the kind of data, the electronic records, maybe claims that are in some of the CDRNs, and there's some real advantages of putting the two together, at least in particular clinical areas. So,
Yeah, I mean, we've got some incredible opportunities for the PPRNs and either CDRNs in the room or other partners that we've worked with or that are around in the country. I know someone yesterday mentioned they work with Aetna and doing that kind of linking. The real nice thing about those insurers are they have a pretty broad view. So they will know that that patient went to Kaiser and to Ocean and somewhere else. So they'll actually have a nice broad view, but you'll have deep granular information about them, about that patient. Putting those together becomes really powerful. So thinking about ways we can do that.
I think there's agreement, you agree with that, but the question is, how is that going to happen in PCORnet?
One-off.
One-off,
to start.
Maybe go back to the back. Press the button.
Sharon Terry, SINA. So our PPRN is set up to do that sort of thing because it functions with the individual at the center. And an example of that we sort of set up ahead of this is with Healthy Heart and with P-Scanner, so a CDRN and a PPRN. Those will be part of the dashboard that individuals will make choices about whether or not to share with. And so if the individual is the central element, then that kind of sharing is much easier with granular and dynamic privacy settings and sharing settings and data access settings. So I think we'll have at least one experiment within PCORnet to try that sort of thing with the connectivity coming through the individual and not through the institutions.
Maybe that's the way to start this off in PCORnet, is with a few select PPRNs and CDRNs that do have overlapping patients and where there's a real clear gain to, that patients can see and consent to in putting the data together.
Yeah, exactly.
Hi, this is Avinash Shanbha from ONC. Just wanted to mention that ONC has been working on patient matching and getting standards for patient matching to kind of be able to link and follow patients. So if there is some kind of harmonization of a bunch of standards or data elements that might make sense for the national level to be able to do that kind of work, we'll be really looking forward to working with you all to get that harmonized and be made it into a national.
Great, I'd love to hear about how you guys are doing that.
And it's just in terms of, and this perhaps is an issue that needs to be resolved today, it sounds like a lot of this could happen within PCORnet, but at the level of individual PPRNs and CDRNs focus on a specific issue, not necessarily something that would be sort of a new PCORnet-wide data warehouse.
Yeah, so I think we want to avoid that. So when we're doing those linkages, the first question, well, where are the data going to end? What you're trying to do is get the data actually sit together so it can be analyzed. I think having some PPRNs and either CDRNs in the room or PPRNs and insurers that aren't in the room or local insurers that happen to have a good coverage of your area, having some use cases to go out and do it would be, we'll all learn from. I mean, certainly in Mini Sentinel, we've been doing a fair amount of that. We've tried some patient matching work, and we're linking between insurers and state health registries, right? So birth registries and immunization registries to create a richer data source for particular questions. But this can happen. It's making those partnerships. You do have to decide where the data are going to sit, but that's okay.
Devin, is this something that PCORnet could support? It's going to good. Are there?
Well, so I liked the platform analogy from yesterday because it seemed to sort of be the best one to fit what we're sort of initially trying to do here, which is to say that none of these collaborations that you're all talking about are on the table, but they don't necessarily have to be network-wide in order for it to work. So if two PPRNs and a CDRN and two CDRNs or more want to collectively work together to work on a project, a particular research question, that's absolutely on the table. We'll have some sort of policies that are sort of network-wide to enable those conversations to happen, but it will really be, at least from a privacy standpoint, each of your individual networks that are coming together and deciding how you're going to be both collecting and sharing data will have to work through the privacy issues with respect to that, how it works for your institution. We do want to develop models for people to use, so you're not swimming out there in the water without a clue about how to do this. But if your particular institution has a way that you do it and sticking to that allows you to do this work more efficiently, go forth and conquer, right? We're not making everybody sing to the same song sheet, but we're going to get you a song sheet, and we're going to get you models of song sheets so that you have an idea about how to move forward, right? So this is not, one size fits all. We don't have to all figure out one way to do this. We can actually be experimenting with multiple ways to do this and learning from one another in the process. So it's not neat. It's a little bit messy, right? If you're looking for neat, you probably came to the wrong place, right?
Right. I know there are a lot of you. I mean, this is a great discussion. I know there are a lot of people who want to contribute to it. Thanks for the hands up. We've only got about 5 more minutes now. I do want to remind you that we have a session this afternoon where for any issues that haven't been brought up or brought up effectively, completely resolved, we're going to have some more time for input then. So I'm going to try to get to a few more comments now, but for those of you who don't feel like this has been fully addressed or have some more to contribute, we'll try to do it this afternoon too, as well as in the continuing work of the network. The comment in the back there, yeah, go ahead.
Yeah, hi, this is Susan Redline from the Sleep Apnea PPRN, and I completely, understand, especially reflecting on Sean's comments about being practical, about the need for flexibility. On the other hand, I completely, are enthusiastic about the concerns from the COPD group that the power of this network of networks is to be able to share. And the way we thought, also similar to your PPRN, we did conceptualize the patient as being the center of decision making, and we explicitly really sort of put forth this notion of co-enrolling patients across PPRNs. Like in our case, sleep apnea is very common with heart disease and other conditions, and that may be one model of really thinking about how co-enrollment will go. On the other hand, I think that it would be very useful as a network to think of really, in fact, one option individuals could select is whether they were comfortable with this notion of actually having a PCORI ID, so that for future flexibility of potentially really sharing across all networks rather than just co-enrolling in healthy heart and sleep apnea, that maybe that would be amongst the menu of things an individual. And I realize it's very complicated, but I think we should really think about that, because that would be the ultimate altruism and the ultimate flexibility that we might want to lead towards. And and then the other comment I wanted to make is in the issue of goes back a little bit, a few minutes ago, to the issues of data standards and how we harmonize data from PPRNs and CDRNs. And I actually wonder if some of the issue really is thinking of our dialogue is how do we harmonize data that are existing and concurrently being collected in our health systems versus as a network, how do we think about some common approaches for prospectively collected data, especially through the PPRNs. And I think part of it is through the patient-reported outcomes group, identifying those instruments and making them available and annotating them so we understand what are the best ways. But part of it may actually then go back to the data standards group and think about prospective data in terms of what is the format, the structure, the vocabulary, the canonical data dictionaries that we might actually want to adopt, as they're convenient, just to help with, future harmonization.
Thanks for the comments. Jennifer?
So just want to channel 2 people. One is John Pirro, who's the information architect at Ochin, who's listening on the webinar and has been texting me ideas because he said he wasn't able to get into the webinar. And his comment is really it would be nice to agree on a minimum core data set of standards that we could then add individualized additional data for disease cohorts, patient-reported outcomes, et cetera. So some core standard. I also want to channel the health systems about, again, being somewhat organized. They're being besieged by everyone telling them, we want you to measure things differently. And so they've got quality measures coming at them from meaningful use, the ONC. They've got payers telling them to do things. They've got individual state entities telling them to do things. And part of what we're trying to help them do as researchers is figure out, let's all measure things together in a similar way. And yeah, maybe researchers want to go a little more in depth or have a little more information, but let's make sure that we're coordinating with our health systems who are also trying to develop standards for data and measurement as well. so that we're not giving them one more set of data, especially the data folks who are pulling data for multiple folks, so that at the point of care, for the quality measures for the policymakers and for the researchers, we've got at least a core set of standards.
So just we only have time for a couple more comments. I'm going to try to get to a few here. But it does sound like there is a good bit of support for the, as I call it, a common data model for use in the distributed analysis, but also some support for going beyond that in some ways, not just in terms of sharing best practices for how to deal with things like overlapping patient populations and wanting to get the same information shared across CDRNs and PPRNs working in a particular area, but even maybe standards for some of those kinds of activities as well. Now, there's clearly a lot of work ahead on how to find the right balance and where to begin and how to prioritize, but it does seem like some common ground in a lot of these comments, so go ahead.
Rebecca Sutphin from the About Network, but I'm also...
press the button, make sure that's on.
I did. Can you hear me? Okay. Yeah, from the About Network, but I'm also a co-investigator at the Data Coordinating Center for the Rare Disease Clinical Research Network, and I see a lot of other people in the room, and Peter and Rachel Richardson, who's on. And I'm going to kind of just summarize maybe a couple of points that I agree with. One is, if there's an opportunity, this last point about a set of common data elements that at least is a core set, in other networks, and I know other people in the room have been involved in these other larger networks of networks as well, and there can be such value in that over the long haul. And then the idea, and then we have help, from OCN and people like that. I think Susan's comment about the PPRNs especially being in a position to try to agree on some of these common elements, and that's what we found in rare diseases as well, that there are things we're going to commonly collect, and if we can agree on those right at this outset, it's going to be so much easier down the line, and why wouldn't we? We need to establish our standards anyway. And then to Amy's comment about, I think I would just encourage people, for the PPRNs especially, put somebody on each of these task forces as much as you can, because I agree that the PRO task force, the rare disease task force, the data standards task force, each of these is going to have a piece in this, and there's got to be some communication across the task forces as well as at the steering committee level, so that the work is being done in a kind of coordinated fashion.
Thanks for the comments. One more quick one up here.
So I just want to throw yet another angle into this discussion. So we're patient-powered research networks and patient-centered outcomes. So I just want to remind us that most of our patients or people with diseases not only willing to donate data, but also willing to analyze data. So as you probably, all of you heard about crowdsourcing. So the model that we're discussing here probably may not allow crowdsourcing opportunities. So for others outside us, outside our networks, to just being able to download, review data, and analyze ad hoc. So because all our patients, they have either their own knowledge how to do this, or affinity groups and networks who are willing to help them to analyze data, and we have some experiences in this. So I was wondering, what about your comment on this?
I would also like some final comments as we're wrapping up this session. It's a very good question. It's great to have as much PPRN representation here and to see how much patient perspective and experience they're bringing into PCORnet. But the idea that we talked about yesterday was having some methods come out of this work that would enable much broader contribution of data to develop evidence, even going beyond the existing PPRNs. Do you see how these standards and some of the approaches that we've discussed today could feed into that?
So, yeah, there was a comment yesterday, and I quickly scribbled it down. It was really about who else can analyze the data. How do you let not just the folks in the room or the folks at fancy universities do it, but beyond that? And actually creating a network that has some kind of controls in terms of kind of being able to send questions out. If we can figure out ways of standardizing the question, it's not complicated to give other people the ability to ask the question. Now, I'm not proposing to make that a public website, although that's a switch, right? You could, but I don't think anyone here would be happy about that. But there are ways in terms of having, because this is a network that the questions are sent to the data, you could start to, one, within your PPRNs, allow more access to asking questions, actually using the tools we have, and expand that. So there are things you can do in there. I mean, there's a lot of questions about how to do it best and what resources to devote to making it easy, because it's not the idea of just download the data. It's how do you analyze it. But I think it's important to be thinking about that, to not let it just be the folks who know how to write R01s. Right.
Devin, any final thoughts before we wrap up this session?
A couple. One being that the next time I'm on a panel, I want to be on with somebody who deals with standards issues, because I thought privacy was a hard issue. Standards trumps privacy every day, clearly. Rarely am I on a panel where the conversation doesn't revolve around privacy, and that in some ways is welcome, because while it's a set of difficult issues, they are a set of manageable issues when you want to get there. If your goal, if you're not trying to get to yes, the privacy rules will give you every excuse in the book not to. But if you are trying to get to yes, the rules enable you to get to yes. You can ethically get to yes. And our job within our task forces is to equip you to help develop some of those tools that enable you to get to yes. Circulate the tools, learn from one another, and ultimately have some good policies at the network level so that the network sharing is never the issue.
Jeff, any other final thoughts?
Yeah. So I think one of the things I'm kind of realizing when building these networks, I've been involved with a bunch of different networks. One of the things that worked well in Sentinel was if there's lawyers in your institutions that have questions, have them talk to lawyers on this side, right? So you don't want your investigator talking to your local lawyers and trying to come to an agreement. It won't happen, right? And we do the same for the informatics folks. Don't have the researcher or the MD who's not an informaticist trying to talk to your security officer about the security of something, right? So this is, I was taught when I was consultant, if your client shows up with an epidemiologist, you show up with an epidemiologist, right? So, and I think the PCORnet, it's our job on the task force is to help with that. So we have those resources. So if you find yourself in this conversation, whether it's the informatics security officer, don't feel like you have to do that. There's help to make those connections with the lawyers. When you find yourself in that room and you don't have the tool you need, which is another person, call for help, because that can just be months of delay where you're just talking like this, and if you get the right people in the room, they'll all nod and agree and move forward. It's a lesson we've learned the hard way.
And the network will provide that help.
Yeah, certainly, right? And actually, that's one of those learnings, because one of the things you figure out is if you can say, you know what, this CDRN agreed to it, it's easier for the next CDRN, either for the next lawyer or information.
And why they agreed to it, right? Because
it does help.
Again, it's like, here's how we thought the risk was well managed. Here are the steps that we took. Oh, I get that. That makes sense. Again, unless you're trying to say no, in which case, but if you really are, you want to get there, and your whole team wants to get there, but you just, you need a lawyer talking to another lawyer so that they speak that language, we can do that.
Great. I'd like to thank all of our panelists, Jeremy and Absentia, for